Maybe I should be here for that class. I will be diagnosing myself.
Are
you addicted to like coffee?
Okay, so I found the key.
Yeah, it was there. You probably just looked.
I want that one. Yes, it does. Sure does.
Sure does. Purr.
What did you just say?
What are the goals of that?
For May 18th. Which is a Thursday,
It's the same thing. Stop.
Epilepsy. Exile. Let's not set aside. It was just the holding spot where my students had to write.
Oh,
So, yeah, one of them doesn't have any links to it. It's just.
so is this thing open? We can do it?
Yeah, it's open.
Okay.
Yeah. And it's just 18, 19, 20, and 21. Adrenergic, sympathetic and parasympathetic.
And when do you think you'll be able to post 20 and 21 for the power?
20 and 21. Probably tomorrow. I want to review them and make sure. Yeah, I just like to go through them. Maybe today, maybe tomorrow.
Okay.
I'll shoot for today by the end of the day, midnight.
Because it seems like that's like the best option.
Is it?
Yeah, I'm not very good book person.
No.
So, but your PowerPoints are like.
I try and get to the point, and the college makes their own. If you see it on the overview page, they make some other general PowerPoint that may or may not be helpful.
I'm going with what you're doing.
Just how we do it.
So I have someone quickly.
Yeah, exactly. That's what I always say. Let's do, all right, attendance, Losi back here, Rain back here, Lourdes, not here yet, Tracy, not here yet, Sydney back here, Octavio, not here yet, Cody here. All right, Mandy here, Susanna, I saw you here, Colby, not here yet, Larissa here.
Somebody told Colby was gonna be late. Hers having issues.
Oh, Hannah here, Angelica over in the corner. We'll put the bad girls, Adrian's not here. Gabby. Is Gabby here? There's Octavio. Oh, I just called your name. You're just so lucky.
I do, right here.
Megan here up front. Naveen over there. Neil over there. Steph is here. Chris over here. Gwen back there. Is Gladys here? Not yet. Sierra. Is Megan here?
Yeah.
Oh, she's right here.
Okay, I thought I saw her, so I walked through here, but then, Miguel, you're here. Forrest over there, Mastera, not here. Mayor is here, Tori is here, Natalie, not yet. And Destiny. Boy, people just did not want to get up today from the class.
I mean, I can understand. So yesterday it was so early.
All right, so quiz number 3 is posted. It's been posted for a couple days. Apparently, I have a holding place one and the real one. Let me get rid of the one that just says whatever it says. It was just a holding place to remind you that there was a quiz until I made the quiz. Week 5. See if I can find it.
What?
I don't see the other one. There it is.
I have one. I got black and red.
Quiz 3, choose 1, quiz 2. I don't know, I'll have to fix that later. All right. Who came in that I need to mark here?
Tracy.
Tracy. Anyone else? Who else came in? They told me you were here and I saw your stuff, so I marked you here. All righty. Any questions about anything? Anybody?
Yeah.
Just have to let me know when she arrives. Like, change her from absent to present. What is?
No.
No, she moved it.
Oh, okay.
I was she moved it back.
Okay, so the plan today is substance use disorder and hopefully all of adrenergic and adrenergic blockers. Yeah, because we need to get cholinergic and anticholinergic on Monday because the exam is next Thursday. And it's a big exam, it's a lot of chapters, it's a lot of drugs. Studying now. Wait until 2 days before, you will not do well. It's a lot. It's very straightforward in my opinion. It's nothing trying to trick you. It's just, do you know the information? Do not know the information. And it's, do you know the information and can you apply it to this particular patient scenario? If you didn't do well on math or if you didn't do well on the math quiz, please get help. That's 10% of your exam. Right? You can bring your grade up if you just get the math questions. That's like 5 freebies. And they are the same types of questions we've been doing. Calculate a dose, calculate intake. Calculate a dose, calculate milliliters or liters or ounces or milligrams or grams. It's nothing new. Do your workbook that does the calculate with confidence. Do those practice exercises and you will do well. All right, let's see what we got here.
No, I just was like.
Don't sleep in the back. If you sleep, I call on you.
Okay.
Can we sleep in the front?
Yes. So I can be right here and say. Don't sleep through any of it. This is so important. Oh, we should. Warning for now. At least it works. That's- Is that auto? Yeah, I turned it on. All right. So we finished with all the psychotherapeutics. You are now experts on all of them. Mental health disorders, and how to treat them. So we'll move on to substance use disorder, which I forget how many questions there were on the exam, but just the basics of it is really kind of what's important. All right, so we've already talked about opioids, they're substances of abuse. We know that dextromethorphan, which is a cough suppressant, which we won't get to really until we get to the chapter on coughs and upper respiratory illnesses, but dextromethorphan, which is the DM and cough medications, does act on opioid receptors, so it's the latest and greatest substance of abuse. And probably at some point will be taken off over the counter and moved behind the counter, and people continue to abuse it for the high, because it acts on opioid receptors. So be aware of that is kind of a out there and cooking. So we need to know the drugs to treat opioid dependence. The goal, remember we talked about what's the goal of therapy in Parkinson's, what's the goal of therapy in epilepsy or seizures disorders. We need to know what's the goal of therapy. So we want to reduce doses gradually, so they experience the least amount of withdrawal symptoms so that eventually they can live a substance-free life. However, we know that it can take, just like cigarette smoking, any sort of substance, including cigarettes, can take multiple attempts to stop before people are successful. Don't give up on our patients. The number one drug they use is methadone. So how does that make sense? If methadone is an opioid, why do we give an opioid to an opioid addict?
Wean them off it.
No.
No.
No?
Well,
I mean, why do we give an opioid?
That's their side effects.
So what do we know about methadone? Do you get a high with methadone?
I don't think so.
Typically, no. That's why it is the opioid that we use. Because it's a replacement without getting the euphoria, and it's super long acting. So this is sort of, we'll go through kind of the time frame of opioid withdrawal and what you see. So if they give you a patient scenario of something presenting to the emergency department, and they give you a hint that you will recognize, hey, here's our symptoms. These are terms that you should know. They expect you to know the dryasis, diaphoresis, rhinorrhea, lacrimation, medical terminology, because you are medical professionals now. So make sure that you know what they mean. We treat the symptoms, especially elevated blood pressure, with clonidine. So we treat symptoms. We treat respiratory depression with the antagonist. We treat if they're coming off and have an elevated blood pressure, we treat with something. So we're treating the symptoms. We haven't. Why are we cursed with this? Serious. And of course, the intense desire with muscle cramps, aches, and anxiety. And we're trying to really lessen the withdrawal, because oftentimes that's the reason people just stay on the drug, despite okay, so yes, there's the euphoria, but also the dread of the withdrawal symptoms, right? It's like going to the dentist, you got to do it, but you dread it. Well, same thing with the withdrawal symptoms. People stay on opioids because the withdrawal can be hell. We talked about naloxone. It's the standard with first responders. It's now going to be, according to the FDA, available over the counter, not just behind the counter for testing purposes. At this point, it's still behind the counter, but this was in the last couple of months. The FDA said, why are we restricting a life-saving medication? We should be putting it out on the street corners, So the other one, so this is naloxone we use acutely for someone who is experiencing an acute overdose. They have respiratory depression, they are unconscious. This is how we bump the opioids off the opioid receptors and replace them with naloxone. Naltrexone is used for maintenance. So we have methadone, and we also have naltrexone.
So some of you might recognize the term Suboxone, people going to Suboxone clinics in order to get treatment on a regular basis. Sometimes that's mandated by the courts for people who've been in jail for substance-related issues. So naltrexone is the maintenance drug, one of them, to maintain abstinence, right? It's a naloxone type drug. Naloxone is acute. Naltrexone is maintenance. That's sort of the difference, sort of like when you're dealing with COPD and asthma medications. You have your albuterol that's for an acute break, and then you have your controller med. Same thing here, acute and controller. The rule is you have to be off the opioids for a week in order to begin. And so that's usually when people are in detox and we're managing symptoms and whatnot. So that's opioids. And opioids, are they a stimulant or a depressant? Depressant, right? They fell under the class of CNS depressants. The adverse effect of overdose is respiratory depression. So put it all together, this is in the depressant category. Now we talk about stimulants, drugs of abuse that are stimulants. So a lot of these are street drugs, and then we talk about methylphenidate, which is Ritalin, right? Remember when we talked about ADHD, and methylphenidate is a central nervous system stimulant used for ADHD, but it also gets misused, right? Similar things. Everybody's looking for the upper. Oh, and so that's just the mechanism of action. It acts to release norepi, causes CNS and cardiovascular stimulation, which is why you get all of these sort of increased alertness. You feel invigorated when you're on them, and it's all because of this central nervous system stimulation. Your blood pressure's up, your heart rate's up. Then unfortunately, we have some adverse effects. People end up in the ED with cardiac dysrhythmias because of all that upper stimulation. Obviously, you can only up so much before your heart and your other muscles react. Remember, these were some of the drugs that were used to treat these conditions, and they just are misused. You know, mom takes kids' ADHD meds for the upper effect, or buys them on the street, or whatever it is. So methamphetamine. So we talked about amphetamines, the forms of amphetamine that are used in these ADHD, narcolepsy type disorders. Meth, we know obviously is a street drug. Those are all the street names out there. Ice, crystal blast, crystal meth. It's, you know, you can snort it, you can inject it, you can take it just about any way that's available. So that's methamphetamine. So pseudoephedrine. So pseudoephedrine, or Sudafed, what do we use Sudafed for? Decongestant, right? So why is it regulated if it's pseudo? If it's not like, it's not meth, it's pseudo, right? Everybody knows, right? Breaking Bad, what did he cook up? And he cooks it from, typically gets cooked from pseudoephedrine.
Oh, so it's like,
It's a precursor to make meth, which is why pseudoephedrine is now behind the counter, and you can only buy a certain number of milligrams in a 30-day period. It's because it's the precursor, and you can cook it up and make meth. So let's have people look up, try and see what the rules are. See, I already told you where you can get it. It's behind the counter, right? Behind the counter means at the pharmacy window, you just ask for it. How old do you have to be in the state of Utah? Google it. How old do you have to be to buy it? 18. Is it 18? Is it 21? Is it 25? Is it 16? That's what Google's for.
Legal age to buy pseudoephedrine?
Uh-huh. And states and federal may have different regulations, and so whichever is the more restrictive. How old do you
Yeah,
have?
18.
18 in the state of Utah? Okay,
Can't
so
have more than 3.6 grams per day.
3.6 grams per day. Yep, and then what does the pharmacist have to see when you go to get it? Your ID, because they're logging it into the database so that every other pharmacy has your name and you can't go pharmacy shopping. Same thing like opioids, right? We have a controlled substance database. And every time I'm prescribing something, I'm looking in there to see if you're shopping for it. What's the legal maximum you can purchase? Andy told us 2.6 milligrams or grams? Gram, 2.6
Per day.
grams per day. Okay, and I think that's more restrictive than the federal mandate about what's the restriction. Utah, we like to restrict. So we know that pseudoephedrine, the brand name that's been on the market forever, is Sudafed. So what's the difference between Sudafed and Sudafed PE? Because Sudafed PE is on the grocery shelf.
Does it not have that pseudo in front of it?
It doesn't have pseudoephedrine in it. It has phenylephrine, so it has a substitute ingredient in it. That's not quite as effective, but you also can't cook it up and make meth. So when you're educating people about drugs and what they're buying, if they have been told to buy Sudafed, you need to be clear which Sudafed are they supposed to buy? Are they supposed to buy the one that's over the counter, or are they supposed to buy the one that's behind the counter? They work differently. They're both decongestants. Anyone who's ever been congested knows that pseudoephedrine works way better than phenylephrine. So I don't even say this one. Methyl dioxymethamphetamine, MDMA, another drug of abuse. Ecstasy E is another drug of choice for abuse. Just have to recognize that it's MDMA, drug of abuse. It is an amphetamine, doesn't have as much of the upper as like meth does. Drug of choice for raves. I don't know how true that is. That's what I'm told. It's the drug of choice for raves. We know about cocaine. Here's all the great slang terms for the powdered form, all the great slang terms for the crystallized form, just like meth. You can take it in just about any form you can get. Obviously, people want to take it. Do they want to take it enterally or parenterally? Which is the preferred route for drug of abuse? Parental, right? Because why? Right, you get directly into the bloodstream. You don't have to. Who wants to swallow cocaine, have it in your gut, have to wait for you to, metabolize and all that? No, you want it right into your bloodstream. Parenteral. So there are a zillion and then some adverse effects of all of the stimulants. And you can deduce them from what does the stimulant do? And if we get too much stimulation, what would it look like? So if my heart is too much stimulated, my heart is too much stimulated. If my heart is overstimulated, what would that look like? Like tachycardia, elevated blood pressure, perhaps angina from the demand on your heart. You may have, what would it look as far as, say, cardiovascular? Anything that raises your blood pressure can cause a headache. If you have vasoconstriction from this, that's one reason you may have a headache. You may have flushing, heart rhythm issues, GI. These are all sort of like people who are on stimulants often have lost a lot of weight, right? You see the very cachectic, emaciated face. Oftentimes teeth fall out because they've lost all of their appetite. They've lost weight. For a lot of people, that's a great effect, but when you start losing the teeth from it, not such a great thing. obviously some of the psychological effects start to look like perhaps schizophrenia, when we start to have paranoid hallucinations and be delirious and want to murder somebody. So lots and lots of adverse effects. I would learn them just generally as stimulation on overdose, right? Stimulation on steroids. So this is what happens typically with these stimulant drugs when people overdose and die. It results in seizures, coma, brain bleeds, death. Unfortunately, I should have asked you before I put that up there. What's the antidote? Yeah. No real good. We know there's an antidote for opioids, but that's a central nervous system depressant. As far as stimulants, we don't have real good antidotes. What we have is just, we got this patient in the ED and we're providing supportive care. Pretty sad. This is the withdrawal period for stimulants, similar to opioids. So what the signs are, I like this. If you came off of a stimulation, what you have is kind of a rebound depression, right? Your system has been stimulated for so long, and you withdraw that, and everything kind of drops to the floor. So psychomotor retardation, depression, and wanting to sleep, and just kind of the opposite of it. Here's the key. We don't have antidotes. So quit smoking crack. Crack kills. Crack kills. Exactly. Besides the opioids, we know that other depressants can be abused. We've talked about the fact that benzos are so addicting. That's why they're considered drugs of abuse. That's why there's this precaution with mixing benzodiazepines and opioids. Not only because they're both substances where people become addicted, but because together they're so deadly. I'm not sure why people really enjoy the downer effect, but perhaps there are self-medicating for trauma, for unaddressed anxiety, PTSD, lots of issues. The military population using substances to cope with military trauma, my experience with the population. Obviously, marijuana, we have this sort of conundrum between it being federally illegal and yet we have state marijuana clinics.
You overdose?
I mean, there's certainly a limit to what's safe, but I don't think we've talked about it. Usually it's a combination with other substances. And we worry about permanent structural changes within the brain from the chemicals being constantly present. We haven't really talked about, or I haven't read about overdoses on marijuana, which is why the pro-marijuana group says, well, this is so much a safer drug than giving people opioids. That's the argument. The only problem is we haven't studied opioids. I mean, sorry, we haven't studied marijuana enough because it's been federally illegal, right? Same thing with mushrooms like psilocybin. We haven't studied them enough because they've been federally illegal and there very well may be benefits. But they are at this point still federally illegal. All right, so very much the opposite, the adverse effects, the very exact opposite of the CNS stimulants for overdose, of the presentation. Somebody comes into your ER. I mean, nausea and vomiting looks like so many other overdoses. How are you going to know the difference? We do know that's the complication. We talk about marijuana. This is what we know so far, is that chronic marijuana use, especially like high daily use smokers, have permanent changes to memory and attention. And this amotivational. It's a great word for like marijuana users are classified as like slackers, no motivation to do anything, right? And here's the medical term for it. Chronic depressive amotivational syndrome. Yeah, slacker. That's what we know from chronic marijuana use. Benzos, usually not fatal alone, although what's the antidote for benzos? Glumazanil. But usually it's the combination of that with other central nervous system depressants that kills people. Little talk on THC versus CBD. So marijuana contains THC and CBD. All CBD products usually contain THC and CBD. But marijuana has more THC, less CBD. THC is the chemical that's regulated so that when we get CBD and hemp products, it has to contain less than 0.3% of the psychoactive component of THC. The problem with a lot of products on the market is because it's not regulated, you can get products that have a considerable amount of THC far and above the federally mandated, like, hey, if it's a hemp product, if it's a CBD product, you can't exceed this. So go figure. So CBD, we say THC is the most prevalent in cannabis, and then CBD is the second most prevalent. So far, what has been studied, it doesn't show any evidence of dependency like the THC can. There actually is an FDA approved use for oral CBD solution, which is for an epilepsy, form of epilepsy. I think it's supposed to say Schedule 5 since there isn't a Schedule 6. That was a typo. And so because it's a derivative of a substance that was Schedule 1, no approved therapeutic uses. Remember, Schedule 1 is where cocaine and ecstasy and marijuana fall. They actually moved this particular drug into a Schedule 5. So it's still a controlled substance, but it does have a therapeutic use. Obviously, you can go to your corner CBD store, pick up any product that they advertise as CBD. According to the Mayo Clinic, like I say, there is no standard for testing, standard for what it contains. And so they did a study of some 84 random products that they bought online, and more than 25% had less CBD than was labeled. So people were taking CBD for whatever they believe the indication is: immune support, sleep, pain, reduction in anxiety, and yet what the label was saying was in it was inaccurate. And 18 had THC that was above that 0.3%. So it's the same thing with all herbal supplements, unregulated. It's a free for all. You don't know what you're going to get. So that's marijuana and CBD. Ethanol, we know ethanol is the most accurate term for alcohol. So when you see ETOH on your intake sheet or in the documentation, ETOH, everybody should know, is the chemical name for ethanol, which is what we call somebody who uses alcohol. So how do they present? Well, they would present with respiratory depression and flushed skin. This is a kind of this weird paradoxical reaction that someone who's acutely intoxicated can have a decreased blood pressure up to 12 hours, and then suddenly their blood pressure can rise really high, can be very confusing. Sweat, pee a lot. Anyone who's consumed alcohol can identify that, a few beers, you're always running to the bathroom. This is just on steroids. So the how ethanol works causes diuresis. Hey, sounds like a great drug for heart failure, right? Diuresis. Oh, just kidding. What are the problems with chronic alcohol use? A lot of it is malnutrition, usually because people are substituting alcohol for food. see this often. So some of the terms that this particular course likes you to know are Wernicke's encephalopathy and Korsakoff psychosis. They are manifestations, psychological manifestations of vitamin deficiencies for alcoholics who not been able to either consume or absorb B vitamins. So sometimes people who, I had a patient who was going to be an alcoholic and his granddaughter was never going to fight with that because he also had some dementia and it caused him to become aggressive. So we just supplemented with B vitamins here, have your B vitamins and down it with your beer in order just to prevent these sort of psychological effects from malabsorption of B vitamins. Seizures, obviously. What do we use to treat seizures? What class of drug? For people who have alcohol intoxication and maybe don't have access and are going to have a seizure, or they're in the ED with alcohol withdrawal. What class of drug do we use? Benzodiazepines. Remember that? I told you need to know this, like the 7 major uses of benzodiazepines. That's one of them. Heart working hard over many years causes cardiomyopathy, which is a thickening of the heart muscle. It gets bigger and thicker. And the one muscle in the body that you don't want big and thick is the heart. Like we love to get big and bulky and work out, but the heart needs to stay very soft and pliant and flexible. So that's pathological. And then of course, hepatitis, which progresses to cirrhosis. So hepatitis, specifically the word means, what's itis mean? Inflammation of the liver. If you have a liver that's chronically inflamed, the body is going to try and compensate, and you get this very scarred liver. A liver should typically be soft like a wet sponge, and things can flow through it very freely. A cirrhotic liver is like a dry sponge. Things don't, it's very stiff, firm, and things don't pass through it well. And then of course, alcohol leads to cancer. We know it leads, chronic alcohol use leads to cancer in at least 7 sites of the body. So it's not just, oh, it's hard on your liver and oh, you might get some sort of psychological changes, but we know it's a cause of cancer. And oftentimes patients don't know that we now have identified 7 types of cancers are directly linked to chronic alcohol abuse. So yeah, choose your poison, I guess. We know it's a sedative, it interacts with other sedatives. We know that this shows up on quizzes and exams, like, oh, an alcoholic comes in with pain. What are you not going to give them, right? Duh. Acetaminophen that's processed through the liver. And then, of course, we have all kinds of issues with warfarin and alcohol. A lot of it can have to do with protein binding, because remember, we have alcoholics often replace food with alcohol. So if you're replacing food with alcohol, you're not getting a lot of protein. Then you have less protein binding sites. If you have less protein binding sites, you have more free drug that's bioavailable, and you have overactivity. Signs and symptoms of withdrawal. So blood pressure, temperature go up, agitation, tremors, kind of, let's see, what does that look, what else does that look like? Elevated blood pressure and temperature. That looks like malignant hyperthermia, except they haven't had anesthesia. Well, they kind of had anesthesia, haven't they? They've had alcohol, which is kind of a central nervous system depressant. So it's kind of like having had anesthesia. That's the kind of the timeline, similar timeline for withdrawal symptoms. So alcohol withdrawal, we mentioned. Benzos are the treatment of choice. We replace one central nervous system with another one that we can control better. So we replace alcohol, that's a downer, with benzos that are a downer, but they're prescribed, and then we're going to slowly wean them off and onto other meds. Clonidine, which we'll talk about, it's used in a lot of cases for blood pressure control. It gets used for blood pressure control in opioid withdrawal. It gets used for blood pressure control in alcohol withdrawal. because it's rapid onset and also quickly out of the body if things change. These are kind of some of the classic symptoms. People, oftentimes if people are really coming out, they may need ICU placement. So what gets used? So there are a few things out there that gets used. Disulfiram or antabuse is the one they ask you most about. So antabuse has been on the market for a really long time. But problem is that if you drink while you're on disulfiram, what happens? Get really sick, right? There's a classic sentence called the disulfiram effect or antabuse effect, where you get really sick and it's caused by the production of this medicine with alcohol, produces acetaldehyde. And so people don't want to stick with taking a medicine that they know that if they slip up, they're going to get really violently ill, like nausea and vomiting, profuse vomiting. I wouldn't want to stay on that drug knowing that I might slip up. So it's luckily they've come up with this newer drug, this acamprosate, Camprol, that doesn't have this particular adverse effect if people accidentally slip up and drink something. We do use naltrexone. Where did you see naltrexone before? Like 7 seconds ago. Where was naltrexone? Substance use, yeah. Which substance? Opioids, right? It was the maintenance therapy for coming off opioids. So naloxone is acute, naltrexone is maintenance, but it also gets used as an adjunct to reduce the pleasurable effects of alcohol. That one's in there. Of course, we recommend, just like people who are under medical treatment for anxiety or depression, we also recommend that psychological component, addressing the underlying psychological component as to why you're using these substances in the first place. How do you find better ways to adapt? All right, which statement does the nurse include when teaching a patient about disulfiram, antabuse therapy? Do we tell them, hey, antabuse will cure your alcoholism? Or if you drink alcohol after taking antabuse, your blood pressure will get very high. Or you cannot drink alcohol for at least 3 to 4 days after taking antabuse. Or if you miss a dose of antabuse, double the dose the next time it's due. So you do need to know antabuse. So obviously that this medicine, the disulfiram, stays in your system for a few days. And so they are at risk of having this acetaldehyde or disulfiram reaction if they consume alcohol in that period of time. Facial flushing, nausea, vomiting, tachycardia, and hypotension. So not hypertension. The worst symptoms they get really is this profuse vomiting. That's not a cure. Obviously, you don't change the dosing. So that's just addressing each of those options. It's not high blood pressure. It's not a cure. There is no cure, and you don't change your dosage. Just kind of go with it. The most common substance abuse, of course, is nicotine. Why do we love nicotine so much? Well, it messes with neurotransmitter epinephrine. So people say that they smoke to relax, but pharmacologically that's incorrect. It actually creates a stressor. Epinephrine creates a psychological stressor. So it's the opposite, but for whatever reason, people feel like they're relaxed. Just like with alcohol and opioids, obviously you get some withdrawal symptoms if you abruptly stop. We know there are no therapeutic uses for nicotine, and we do know there are at least 200 known poisons in cigarettes. So how do we treat? Lots of ways to treat. We try and give the nicotine without giving the 200 known carcinogens, right? We just try and give you some pure nicotine. So all sorts of forms that comes in, patch, gum, lozenges, inhalers, nasal sprays. We'll give you nicotine however you want it, except the ID. Anything to get people to replace that, that substance with something else. We also use bupropion. Where did you see bupropion before? Antidepressant, right? It was an atypical antidepressant that has a clinical use in reducing the urge to smoke. It doubles the likelihood that smokers will quit. This has been on the market for 15 years or more. Chantix is the brand name. Varenicline is the generic. So it is a non-nicotine substance that stimulates nicotine receptors. So you're getting the same nicotine stimulation without taking nicotine. It triples the likelihood that smokers will quit. So you can see why we would want to add one of these particular oral drugs to a nicotine replacement. So which of these do you think might have the fastest onset of action? Now that you know about pharmacokinetics, patch you think has fastest onset? Something that needs to go through your skin. Lozenges or gums or an inhale, anything that's going to bypass any sort of skin barrier. Now, nicotine transdermal system is good so that you don't have to take something over and over and over, right? This can stay in place for 72 hours. And so that's nice for a consistent level of nicotine. But for something that you need for an urgent craving, one of these ones, gum gives a nice burst of nicotine like that. You know, you chew it and the nicotine is released and it's absorbed sublingually and through your oral mucosa. So we talk to people about the different forms. Hey, if you're having an urge, you know, this is what we use for an acute event or a lozenge. Gum helps with the oral fixation. A lot of the smoking, I'm not a smoker, a lot of the smoking addiction, some of the addiction is related to the habits that surround it, whether it's having a cigarette with your morning coffee or whether it's the physical sensation of something between your fingers or it's the oral fixation of something in your mouth. And so some of these, like lozenges, are to replace that, something to do with your mouth, right? Chew gum or have a lozenge instead of inhaling in. Obviously, we need to, this is for vape. Obviously, we need to have, let's see, what are some, I can't remember if this is in there. What are some of the, what I believe there's a warning surrounding Chantix, and in fact, you have to be screened for this before you take Chantix.
Suicide.
Right? Suicidal thoughts or ideation. There's a risk that this particular medicine can increase. But you have to be psychologically stable and under medical treatment if you have had depression, especially with suicidal ideation. It's not to say that if you've had that, you can't be on it. It just has to be stable and under medical treatment. It also gives people vivid dreams and causes low sodium. So let's do this together rather than finding groups. So what are some of the things that we believe about vaping? Because vaping's out there, you know, it's probably right up there with cigarette smoking. It's the latest and greatest thing for the younger population. We know kids as young as junior high are vaping. What do we know about, or what are some of the things we believe about vaping?
Doesn't contain tobacco.
We believe it doesn't contain
Oh,
tobacco.
you talk about vaping or nicotine?
Vaping.
Vaping.
So just vaping
Yeah.
in general, right? What are some of the myths out there?
It's better for you
It's
than
better
smoke.
for you.
That's better for you than smoke. So is that a myth or is that a fact? So why is it a myth? What do we know about vaping, Ben?
Doesn't it actually like the vapor sits in your lungs different, so it like contaminates your lungs more than smoking? Does it like leave like a residue on the inside of your lungs?
So there are, let's go to, let's see, vaping myths.
There's aerosol, the vaping contains air or produces aerosol. That contains harmful chemicals that damage the lung.
Yeah, so we've ended up with a lot of young people, especially when vaping got really popular in the emergency room with structural changes to their lungs from vaping, because of the damage to it. Now, because vaping isn't a drug that gets well regulated, it also has the potential to have carcinogens in it. It's not just this innocent. People think of it, well, it's just like water. I'm just getting either nicotine or flavored nicotine and some water. The problem is that we know, because of lack of standards of purity, that there's lots of other substances in that again are getting inhaled into the lungs. And some of these substances may or may not be carcinogens, but they can be damaging, as you mentioned, to that delicate tissue of the lungs. And so they come in with like a popcorn lung where the alveoli are all damaged. And they're like an old man with emphysema with all this permanent damage to their lungs. There's a great website. There's quite a few about the real costs of vaping. And it's kind of important to be up on that because there's a lot of misconceptions that it's safe. And so you need to know in specific, okay, you know, vaping is known to cause irreversible lung damage. Well, that's not going to happen to me. I'm not going to get addicted. Well, you can be just as addicted to vaping if it contains nicotine as a cigarette, right? Nicotine's nicotine. It stimulates nicotine receptors. You're still addicted. Yeah, lots of cool things on. Let's look under frequently asked questions. What are the risks of vapes? It can expose your lungs to harmful chemicals such as formaldehyde. Formaldehyde, what we use to keep dead bodies stable, right? It's just what you need is formaldehyde, and also toxic metal particles. God, I can't talk. Toxic metal particles such as chromium, nickel, and lead. So that's the last thing you need to do is be inhaling lead, right? Good stuff. So be aware about the risks of vaping because it will come up. There are similarities and differences. So let's do this. The nurses, you are a nurse and you are doing a community class on smoking cessation. So you are reviewing all the effects of nicotine on the body systems and all the approaches to smoking cessation. So in addition to non-drug therapies like going to Smokers Anonymous and, you know, not buying any, so it's not in the home, or finding a replacement for that morning ritual that you used to do. She's talking about Chantix. So how does Chantix help with smoking cessation? What did we say under the little Chantix blurb under varenicline? What did it say? It stimulated nicotine receptors, right? So it stimulates the nicotine receptors, but you don't get the pleasurable effects. Same thing like using naltrexone in an opioid use or an alcohol abuse disorder. You get the stimulation without the, you get the stimulation of the receptors without the euphoria. And that's the goal, is to eliminate the euphoria, stimulate the receptors so you don't have withdrawal symptoms, but get people used to not getting the upper pleasurable effects. And then we'll slowly wean them down and let them have some of the discomfort associated with less. All right. Oh. One of the participants remarks that there have been reports of patients who are taking Chantix, exhibiting unusual behavior. All right. So how do you respond? There's reports, they say, hey, I heard that people do weird things when they take Chantix. Okay, so you have to know, what are they talking about? All right. So people have issued case reports of, especially with people with pre-existing psychiatric conditions, as I mentioned, you have to be stable on your med before you can begin it. But okay, there are case reports that this can happen. People can become agitated, people can hallucinate, people can become depressed. But as long as you're aware of this, the benefits of the drug typically outweigh any low-level risks. So if the risk is 0.1%, that or less, that you might have a worsening of your agitation, that's a lot less than the risks associated with smoking by themselves. So this is the FDA warning in 2008 regarding suicidality. So be aware of that one. One participant says, I don't want to take a prescription drug. What do you recommend over the counter? So what's over the counter? Patches. Right, all that long list. Patches, gums, lozenges, inhalers, sprays. You don't have to take Chantix. You don't have to take bupropion. There's lots of other things on the market, right? Acute relief from withdrawal symptoms most easily achieved with the use of gum. Also lozenges, because you get that burst of nicotine. What would be the best response when a patient or participant says, I can't afford Chantix? You know, I'd love to be on it. Cigarettes cost more. Cigarettes cost more. So that's the book response. Yep. Book response is cigarettes cost more. I think if I said that to a patient, they would never trust me with anything ever again. Because it feels a little bit smart-assy, right? Like, well, cigarettes cost more, but they're saying, okay, I have an addiction. I recognize this. I would like to try a drug, but I can't afford it. So what I would like to just throw out there is there are lots of patient assistance programs. Manufacturers of Chantix themselves, Pfizer has programs to allow people to get drugs. There's lots of discount programs. The most common one that most people know are GoodRx, where you type in this, you type in the drug you're looking for, and you'll see that you can pay 1% of what you would have paid if you had a prescription. It's crazy, it makes no sense, but it's out there. So helping people get access to low-cost medications in order to treat not just addiction, but any old medicine. You are often the first line in helping patients become compliant with their medication therapy because they couldn't afford it and they're embarrassed to tell their prescriber that they can't afford it. Oh, I went to the pharmacy and it was $160. How many times I've heard that? We're like, okay, you're a nurse, you're not a prescriber, but you can certainly help them look up on an app where they might be able to find this with this discount program for $12, $17. So that's my spiel about being a good patient.
Is that really how much it costs? $160.
Chantix is, I've seen it sold for over $400. It just depends.
I can see how someone could.
Yeah, that was when it was brand name. It's generic now. And so it's going to be less, but still, drug companies set their prices at what people are willing to pay, right? It's crazy that you can have insurance and be asked to pay some exorbitant cost for a drug, and yet you can have a GoodRx card or needy meds or whatever, and it's $7, $12, $13. Just having knowledge of this, you can solve a lot of patients' problems. All right, take a break, get up and walk around, spend an hour, because the real fun will begin. Autonomic nervous system, yeah. Go neurotransmitters. It's the best thing ever. Neurotransmitters. It's like second in line after that.
Should be.
Dr.
It's
Carter,
like, there, I was
Yeah.
on my own.
So.
Que pasa?
Well, we were gonna set it, I thought we were setting it up by now, because I was figuring this one.
Over here. I just looked up. So. This is just a price.
Yeah, that's a price range. I like it better on an app, of course, because it's scroll down here and for whatever quantity and strength you put in, it will show you a variety of prices. But yeah, so you can get it for $4 at Walmart neighborhood. Well, you need a prescription, so you still need a prescription, but you can have, you can have the prescription transferred to another pharmacy. So they may have it at XYZ pharmacy, and they went to the window and were told it was, $83. So you say, hey, let's look this up and see where we can get it cheaper. Look, let's sit together and transfer that prescription over to Walmart neighborhood market where it's $4. I've done this 1,000,000 times. May not be good RX. I may go to Needy Meds. I go to various apps. I have them all on my phone because I want to solve a problem so they can take their drug. How much more expensive is it for them to end up in the ER? Because they couldn't get their diabetes drug and now they are hyperglycemic. Yeah. So it's really cool, all the resources that are out there.
One thing I will say about the vaping,
Yeah.
if I was gonna be exposed to secondhand stuff, I'd much rather be exposed to vaping than so this stuff smells so good.
That's out of the addiction, isn't it? That is very,
I've come upon people doing vaping. I'm like, gosh, that's awesome.
just as much as cigarettes were manipulated when the secret documents were finally released about cigarette companies and the manipulations of ingredients in cigarettes. Like
Like cigarettes, you come upon something that's like.
No, well, that's why they ended up doing menthol cigarettes and trying to overcome that flavor barrier. And it's true, but they used all the knowledge from that with vaping. And
I had
immediately started
coworkers who were
flavoring
vaping.
them.
Gosh. Love that.
You are like yeah, it's all the psychology. I think it tastes wonderful. I get the hit of nicotine. It's awesome. Oh,
Sad.
how about that? Yeah.
whatever number that
Do you know what the test, what chapters are covered?
10 through 21.
So 10 through 21.
Is this the biggest one that we've done? They're all big. The first one was the kind of the, just to get you into the mood.
Are you done with that? What you're writing on the board?
I don't know, maybe, maybe not. We'll see.
Yeah.
All right, so let's talk about this stuff. So this entire set of 4 chapters, 18, 19, 20, and 21, really informs a lot of drugs, not only that's talked about in this chapter, but other chapters. So when you see something that says it stimulates a beta-1 adrenergic receptor, or it's an anticholinergic, right now you're just like trying to pull it out of the back of your head. What did I ever learn in physiology about adrenergic and cholinergic? And I studied it and then I let it go because I thought I'd never need to know this again. Well, you need to know it again. So we'll start from the basics. That we're talking about the 2 divisions of the autonomic nervous system. So right now we're talking about the sympathetic nervous system that I always put over here on this side of the board. So whenever I talk about the sympathetic nervous system, whether it's written or not, point over here, because parasympathetic goes over there. So 2 divisions. They are the balances for each other. So without one, if you have an autonomic dysregulation, you may end up with excessive expression. So if you have a dysregulation of the sympathetic nervous system, then you may have an overexpression where that can't be balanced by the parasympathetic. So let's just kind of go through things. So the term adrenergic refers to stimulation of the sympathetic nervous system. So if you see the word adrenergic, think sympathetic nervous system immediately. Cholinergic, parasympathetic. Adrenergic, sympathetic. So all adrenergic agonists basically mimic what's happening in the sympathetic nervous system. We are stimulating normal responses.
with an agonist, right? So these drugs mimic the effects of the neurotransmitters. Everything has lots of names. So the neurotransmitters in the sympathetic nervous system also get referred to as catecholamines. You have to know all of this terminology. You have to know what an adrenergic is. You have to know what a catecholamine is. The main neurotransmitters within the sympathetic nervous system are epinephrine. Of course, there has to be another name. Epinephrine is also known as adrenaline, norepinephrine known as noradrenaline, and then dopamine. There is also acetylcholine, but we're not going to really talk about it. So epi, norepi, and dopamine, or adrenaline, noradrenaline, and dopamine. We're just starting with the terminology. Adrenergics, sympathetic nervous system. What are the neurotransmitters? Epinephrine, norepinephrine, dopamine. All right, so I'm not going to watch this entire video. However, there's a million of them on the internet that talk about the sympathetic and parasympathetic nervous system. So it's really good to watch various videos in order to kind of reinforce it in your head. Let me see if I put a clip or if I put the whole thing. I can't remember. Sometimes I clipped it. Oh, I love this guy. He has an accent.
Adrenergic agonists are a large group of drugs that mimic the actions of norepinephrine and epinephrine, which naturally occur in our bodies. Norepinephrine is also known as noradrenaline, and epinephrine is also known as adrenaline. Now, collectively, the agents that activate adrenergic receptors are called sympathomimetics, and the agents that block the activation of adrenergic receptors are called sympatholytics. So now, to get a better understanding of how these drugs work, let's take a closer look at neurotransmission process in adrenergic neuron. There are 5 main steps involved in adrenergic neurotransmission. First, amino acid tyrosine is transported into the neuron by the sodium-dependent tyrosine transporter. Once inside the neuron, tyrosine gets hydroxylated by the enzyme tyrosine hydroxylase to L3,4 dihydroxyphenylalanine, also known as L-DOPA or levodopa.
Where have we seen that?
Next, L-DOPA is converted to dopamine by the enzyme aromatic amino acid decarboxylase. The second step involves transport of dopamine into the synaptic vesicle, where the enzyme dopamine beta hydroxylase converts dopamine to norepinephrine. In the third step, arrival of the action potential triggers opening of calcium channels and thus influx of calcium into the neuron. The increase in calcium causes the synaptic vesicle to fuse with the membrane and release its contents into the synapse. In the fourth step, norepinephrine binds to the postsynaptic receptor on effector organ, which triggers intracellular response. Norepinephrine also binds to presynaptic receptor, which results in decrease of norepinephrine release through negative feedback. In the fifth and the final step, norepinephrine is removed from synaptic space by diffusing out into the systemic circulation, also by being inactivated by the enzyme catechol-O-methyltransferase, COMT for short, and most of all, norepinephrine gets transported back into the neuron by sodium chloride-dependent norepinephrine transporter, NET for short. Now, once inside the neuron, norepinephrine may be either transported back to the synaptic vesicle for future use, which basically means it gets recycled, or it can be broken down to inactive metabolites by the enzyme monoamine oxidase, MAO for short. Now, let's talk about adrenergic receptors. That is, receptors which can be activated by norepinephrine, epinephrine, and adrenergic drugs. As you may recall from my previous video discussing nervous system, sympathetic preganglionic neurons release acetylcholine, which then binds to nicotinic receptors on postganglionic adrenergic neurons, or nicotinic receptors on adrenal medulla. Now, the adrenergic neuron releases norepinephrine, while adrenal gland releases approximately 20% norepinephrine and about 80% epinephrine. At the end, norepinephrine and epinephrine bind to receptors on effector organs. These receptors are called alpha and beta. Now let's talk about these receptors in more detail. And let's start with alpha receptors.
So that's, I'm not gonna go through the whole thing, but that's sort of the starting point. That's a lot of detail, but you should have heard some terminology that we've heard before. L-DOPA, converting to dopamine. MAO being an enzyme. COMT being an enzyme. So part of this is to place some of these other drugs into perspective. When we had a COMT inhibitor or an MAOI inhibitor, where we talked about we were inhibiting an enzyme that breaks down something. This is kind of how it all happens in sort of a picture form. That's just a single neuron. So the key take homes of it really are sympathetic nervous system, which is, here we go, sympathetic nervous system. We are receiving signals either directly from stimulating preganglionic neurons. Here's acetylcholine, and the end product released is norepinephrine. When it acts on the adrenal medulla, where does the adrenal gland sit? On top of the kidney, right? And there's a cortex and there's a medulla. So you have two different organs within one. Well, when it acts on the adrenal gland, we release norepinephrine and epinephrine. All right, so that's how we get our neurotransmitters. We get our neurotransmitters from stimulation, either to produce norepinephrine or norepinephrine and epinephrine. There's also production of dopamine. We're not hugely going to go into that, but it's pertinent. All right, so we have norepinephrine and epinephrine as our main neurotransmitters, or adrenaline, noradrenaline. Yeah, to go past this one. This is, I'm a visual person. So here we go, sympathetic. We're ignoring parasympathetic. This is our central nervous system. We have a preganglionic neuron, receives acetylcholine, releases norepinephrine that acts on our target organs, on alpha and beta receptors. So our target organs could be the heart, our target organs could be the lungs, it could be the kidneys, it could be the adrenal glands, it could be our pancreas, it could be our bladder, it could be our eyes. But norepinephrine is acting on receptors on our target organs, alpha and beta. And I tend to use the Greek symbol as an abbreviation just because it's faster. All right, the other sympathetic activation starts in the central nervous system, acts on the adrenal gland with acetylcholine as a neurotransmitter, and they produce norepinephrine and epinephrine that's released systemically. So that's in the bloodstream and floats around to the target organs. All right, we're not going to talk too much about nicotinic receptors, muscarinic receptors. That's for another class. All right, so that's the basics of it. Again, there's a visual. Another way to look at it. Whoop. What happened? My whole thing went bye-bye. Open. Oh, opening. That's it. Yeah, you learned it all.
You're on your own now.
That's it. I gave you the neurotransmitters and kind of how they start out. It's all up to you.
So now you should know everything.
Now you see, you know.
Well, that's kind of the trend we're seeing, so.
Smart out. All right. Current slide. So
That's just another way to look at it. One went this way, one went this way. We know we have activity from the sympathetic nervous system to stimulate either the production of acetylcholine or to stimulate the adrenal medulla. We produce epinephrine and norepinephrine. They act on the targets of alpha and beta. All right, sympathetic nervous system. Here's our receptors. We have alpha and beta. We do have dopamine receptors. Alpha is divided into alpha 1, alpha 2, beta is divided into beta 1, beta 2, beta 3. That's how we came up with these. Now, if you know what the action is at these receptors, if you learn those, not if, when you memorize those, you now know everything you need to know. And if you figure out if it's an agonist, it's going to stimulate an activity. If it's an antagonist, it's going to block that activity. That's the basic take home in a nutshell. So you need to learn the activity. So here it is in a little visual form of what happens, but we're gonna kind of take it a little bit even slower than that. This is really giving me grief. All right, let's see if we can see what they talk about when he talks about alpha-1 stimulation. I like this guy. Makes me.
Alpha-1 receptors are mainly located on vascular smooth muscle throughout the whole body, and when activated, they lead to vasoconstriction. They're also located on the dilator muscle of the iris, and when activated, they lead to mydriasis, which is dilation of pupil. They're also located on urinary sphincters, and when activated, they lead to contraction and urinary retention. Alpha-1 receptors are also located in the liver, and when activated there, they lead to glycogenolysis, which is breakdown of glycogen to glucose. Lastly, alpha-1 receptors are also found in the kidney, and when activated there, lead to inhibition of renin release. And as a reminder, renin is an enzyme that is secreted by the kidney and is involved in the regulation of blood pressure. So in summary, activation of alpha-1 receptors leads to sympathetic response. Just think about it. When you are in a fight or flight mode, it's advantageous to have constricted blood vessels in case you start bleeding. You also want to retain urine when you're fighting or running away. And you definitely need extra glucose. Now, what about alpha-2 receptors?
So, alpha-1 receptors act on vascular smooth muscles to cause vasoconstriction. So if you constrict your blood vessel, your blood pressure goes up. So if you have a low blood pressure for whatever reason, and you take an alpha-1 agonist, the purpose is to raise your blood pressure. If your blood pressure is high, perhaps, it's not the first line, but perhaps a blocker. If we block vasoconstriction, we can relax and blood pressure can go down. So they like to think of the alpha-1 in the fight or flight, and it helps to think about, okay, so I need sugar if I'm in the fight or flight mode. I need to make sure that I don't have to pee, so I'm holding on to my my urine. I need to make sure that I can see everything around me. My pupils are dilated. I'm quite visually aware and alert, and I have my blood pressure up so that I can engage. So this is the physiological adaptation from ancient man. So this is supposed to be increased inhibition of renal renin. I'm just going to take increase inhibition and put inhibit renal renin. We'll get to that later. So holding in our urine, we break down glucogen into glucose. We have dilation of pupils. We have an elevation in blood pressure. All right. And when you learn those things, you know what alpha-1 receptors do. Oh, this is really frustrating today. All right, let's let's look at alpha 2 agonists.
He's got a question.
endings, and
The question of the renal renin. So that's.
Ignore renal
inhibit
renin
the-
for right now. We're not gonna even talk about renal renin until we get to cardiovascular meds, when we talk about the renin angiotensin aldosterone system. I usually leave that out because it starts to get confusing. So pay no attention to renal renin at this time. I would focus on vasoconstriction, causing increased blood pressure, holding on to urine, increasing blood sugar, and pupil dilation for the purposes of what you need to know. We'll get to renal renin in a bit, but not for this exam.
activated, they cause decrease in
Let's go alpha
production of
2.
intracellular CAMP,
Don't worry about
which in
that.
turn leads to inhibition of further release of norepinephrine. Additionally, alpha 2 receptors can be found on the pancreatic islets, and when activated, they lead to decrease in insulin secretion.
So
Now
alpha
let's-
2 is sort of a balance to alpha 1. So if we are inhibiting the release of norepinephrine, then we don't have a lot of stimulation for alpha 1. If we, alpha 2 balances and inhibits insulin release, acetylcholine release. So remember, acetylcholine was the neurotransmitter here, norepinephrine is here. So it's a bit of a balance for alpha 1. It's a nice, our body has multiple checks and balances. So not only do we have a parasympathetic nervous system which balances this, within the sympathetic nervous system, we have a balance to alpha 1 with alpha 2. Kind of a take home of alpha 2. So don't do a lot with it. It does have a place in anesthesia. Let's go back. Yeah, so oh my heck, this is crazy. There's poltergeists here today.
It
Or
was
does-
in foundation on Monday.
Gosh, between the bang bang and the ghosts. So for it decreases the release of norepinephrine and acetylcholine, it's the negative feedback loop. So if we are blocking the stimulation or production of norepinephrine, then we get the reverse of this, or the prevention of vasoconstriction, which causes a decrease in blood pressure. The medicine that is an alpha 2 medicine is clonidine. Where did we see? We've talked about clonidine quite a few times. We said if we use it in a hypertensive emergency for someone who comes in withdrawal symptoms, perhaps opioid withdrawal, and they're in a hypertensive crisis, we give clonidine. So this is the category of drug it falls in. Is an alpha 2 agonist, and it's acting to inhibit the release of norepinephrine, so we are not having vasoconstriction. We love alpha 2. I'm just going to stand here and not touch anything. Let's look at what he has to say about beta 1.
And when activated, they lead to increased heart rate, increased cardiac contractility, and increased AV node conduction. Beta 1 receptors are also located on the juxtaglomerular cells in the kidney. And when activated there, they lead to increased renin release, which results in increase in blood pressure. Now, let's move on to beta 2 receptor.
Okay, so beta 1 mostly is acting on the heart, and it's acting to increase heart rate. Anything that increases heart rate is called a positive chronotrope. And because chrono refers to time, and yes, you do have to know these terms because they show up. Anything that increases the force of the contraction is called a positive inotrope. Yes, you have to know this term, increased force of the contraction. Anything that increases the conduction time through the AV node is called a positive dromotrope. 3 terms we talk about: chronotope, inotope, dromotope.
And so if we say that a drug is a positive chromotrope, we know that it's increasing the heart rate. If we say it's a negative chromotrope, we know it's decreasing heart rate. It's just terminology, just like we learn things like absorption, distribution, metabolism, and excretion, or you learn adrenergic and cholinergic. It's just terminology that you have to learn. Oh, there it is in that one.
Doctor.
Yeah.
So conduction through the AV node or increase in conduction through the AV node, that's the dromotrope.
Chromotrope, inotrope, inotrope, and dromotrope. There are other tropes that you don't have to learn, but these are the ones you do need to know. Jiminy Christmas. This is crazy.
Oh, sorry.
Let's look at beta 2. I'm just gonna use the same guy since he's so good at it.
And when activated, they lead to bronchodilation. They're also located on the vascular smooth muscle and the arteries of skeletal muscle. And when activated, they lead to relaxation of blood vessels, or in other words, vasodilation. They're also located on smooth muscle in the GI tract and uterus. And when activated there, they lead to smooth muscle relaxation, which in GI results in decreased motility. And in the uterus, it can cause inhibition of labor. Lastly, beta 2 receptors can be found in pancreas. And when activated there, they lead to increase in insulin secretion. And now, before we move on, let's not forget about beta 3 receptors. Beta 3 receptors are mainly located in adipose tissue, and when activated, they lead to increase in lipolysis, or simply breakdown of stored fat. Beta 3 receptors can also be found in the urinary bladder, and their activation there is thought to cause relaxation of the bladder and prevention of urination.
Beta 2. So beta 2 acts on the lungs. The main class of drugs we think about in beta 2 are for bronchodilation. So you stimulate beta 2 receptors in the lungs and you get bronchodilation. Great drug for asthma and lung disease when we can induce the lungs to open up and conduct air passage better. Also causes vasodilation. So if you vasodilate, what happens to your blood pressure? Blood pressure goes down. And if you increase insulin secretion, what happens to your blood sugar? What is insulin used to do in a diabetic? Increase or reduce blood sugar? Reduce. So here we have reduced blood glucose. So look, there's checks and balances everywhere. We have a balance to alpha-1 here. All right, but we have a balance of alpha-1 with a beta-2 because we have a vasodilation and here was a vasoconstriction. Here we have the creation of glucose. Here we have the reduction of glucose. Just memorize them, where they are, what they do. I know it's a lot. Once you have it in your head, this will all be easier. Beta 3, we're not going to worry about the lipolysis. We're only going to be talking about beta 3 drugs that act on the bladder in order to relax the detrusor muscle, which increases bladder capacity, and we use it in overactive bladder type situations. All right, beta 2. So that's beta 3. I just kind of does a lot of other things, but basically we're just looking at the bladder.
Quick question.
Yeah.
We said it reduces the function of the detrusor muscle, which increases bladder capacity.
Yeah.
I guess that it removes urination.
So if we increase the bladder capacity, we are less likely to need to urinate, right? If you have an irritated or
tight or easily stimulated detrusor muscle, then your bladder fills quickly, or you feel like it's full quickly and you have to urinate a lot. If we relax it, you have less stimulation of feeling full and you feel better. You fill that bladder more. That's the placement is in treating people who have this overactive bladder. They're getting signals to their detrusor muscle that they're full when they're not full. So if we can block that and we can allow the bladder to fill more fully, we won't have to urinate as frequently.
So is that what happens where if your beta-2 receptors are not working, which would increase your blood sugar, which would ultimately affect the receptors?
No, I mean, obviously these are not discrete receptors because you can have receptors in other places than what's listed here. What I would encourage you to focus on is, okay, if we stimulate alpha-1 receptors, what are the responses I can expect to see? I can expect to see increased blood pressure. I can expect to see pupil dilation. Okay, there may be times where we want pupil dilation, such as we're going to do a procedure on the eye. We might want those pupil to be dilated. So, hey, we know that we have a mechanism of a receptor that we can act on, right? I think what we want to know with beta-1 is stimulating it increases the speed of the contraction, the force of the contraction, and the electrical conduction through the AV node. So lots of things we might want to address with people who have bradycardia, heart failure, dysrhythmias. We have targets. And with beta-3, we're just thinking that if we stimulate beta-3, we're gonna relax the muscle there or reduce the stimulation, urge to pee, the bladder fills better. We don't have to get up and pee all the time. Really just focusing on the targets and what their actions are. If you get too lost in the details, then you will never absorb all the information that's going to come at you. Yes, I would love to teach you every last thing, but we're going to keep it kind of basic. There are dopaminergic receptors. Remember that we did have L-DOPA converted to dopamine. And so there are some dopaminergic receptors. What we want to know about in this particular case is that the sympathetic nervous system dopaminergic receptors, or the sympathetic nervous system's receptors for dopamine that we're talking about, act to vasodilate. And they vasodilate in the brain, the heart, the kidneys, and the mesentery. So basically giving us greater blood flow everywhere. That's the function I want you to focus on, dopaminergic receptors. Let me put like dopamine. Which increases vasodilation. I-O-N. Basically everywhere. So get better blood flow everywhere. So what we're focusing on here is just the dilation of blood vessels, resulting in increased blood flow. For the purposes of this course, that's what we're focusing on. Getting more blood flow to critical organs, brain, heart, kidneys, and internal organs. And that would be critical in cases of septic shock, hypovolemic shock, where we need to maintain perfusion, which is why we might want to act on dopaminergic receptors. So we're just going to kind of keep it focused on the actions for the drugs that are specific to this course. When you go to medical school, you will learn it much more. But I just try and keep it to what you really need to know to pass your NCLEX and be a safe beginner nurse. You can listen to this on your own. This is Dr. Mike. He goes over it in a different way. I'm just a huge fan of learning it in different ways. As I showed you, I gave you a visual going this way, and I give you a visual going this way, and then you watch videos and you create flashcards.
and it will start to sink in. But basically, it's a lot of memorization. All right, so we said catecholamines are substance that produces a simple sympathomimetic response. So the catecholamines are epinephrine, norepinephrine, and dopamine. They are the neurotransmitters. Catecholamine, neurotransmitter. They are mimicking the sympathetic nervous system. All right, so these are the ones that our bodies produce. These are the synthetic substances that we will talk about. Again, in the little diagram, these substances are broken down by monoamine oxidase, which is an enzyme, and COMT, which is an enzyme. So if we want a substance to remain around longer, we interfere with its breakdown. Another mechanism of action of the drugs that we talk about. So alpha-1 receptor agonists have lots of uses. So we can use it, like I say, in shock and hypotension and hyperperfusion and cardiac arrest, heart failure, and then some other conditions. So this is a great one of the adjunct drugs to treat shock is we head towards something that we can immediately get vasoconstriction and we can get blood sugar up. We're going to use alpha-1 as a target. All right, so we have some vasoactive adrenergics, meaning we're acting on the vasculature. So let's talk about the vasoactive ones. Again, more terminology. Vasoactive adrenergics are also called cardioselective sympathomimetics, right? This is the same thing, different words. Adrenergic, a sympathomimetic, vasoactive, cardioselective terminology. So when we're using vasoactive adrenergics, we're usually doing this if you're in the ED or in the ICU or you're responding to a code. These are the drugs often that are used for an arrest or septic shock. We're going to kind of learn them. So, go back one. Vasoactive adrenergic. Vasoactive adrenergic. Non-selective, meaning it's not acting on a specific receptor. It's kind of a shotgun approach. It's hitting a lot of receptors. So epinephrine is a vasoacting adrenergic agonist, meaning it's acting on the vasculature. It's doing what our normal neurotransmitters do, but it's not selective. We get a lot of activity. We hit both alpha and beta receptors. Usually we don't care because we're trying to keep a person alive. We're trying to bring their blood pressure up. We're trying to increase blood flow to critical organs. This is epinephrine, also known as depressant. So the three drugs, epinephrine, norepinephrine, dopamine, we consider them all pressors in this situation because we are pressing the blood pressure upward, right? So epinephrine, when it hits an alpha-1 receptor, vasoconstricts. When it hits the beta-1, we get increased heart rate, increased force of the contraction, increased speed through the AV node. Kind of important. So if your blood pressure is real low, you're in shock. You want to bring the blood pressure up, and then you want to stimulate the heart to pump it. Doesn't do any good to bring your blood pressure up if your heart is struggling to pump that fluid around. So we also get stimulation to pump, and we tell it to pump hard. Norepinephrine, same thing, vasoactive, non-selective. So it's acting on the vasculature, but it hits a lot of receptors. This one mostly stimulates the adrenergic receptors. So most of them are here.
less beta 1, no beta 2 or beta 3. So norepinephrine or Levophed is more selective than epinephrine. Again, same uses, hypotensive, shock, cardiac arrest. It's a pressor because we use it to, it's supposed to say increase heart rate, not decrease, and increase coronary artery flow. And that's from hitting some of the dopamine receptors. Remember we said dopamine receptors open up the vasculature so you can get more flow to the brain, heart, kidneys. And this one is only by IV infusion. So going to be in a very controlled environment. So epinephrine, wider scatter of hitting things, norepinephrine, mostly alpha 1, a little bit of beta 1, then dopamine. So we can give dopamine, but it doesn't just stimulate the dopamine receptors. It stimulates alpha 1 and beta 1 and dopamine. It has this dose, different therapeutic effects at different doses. So at low doses, it's going to dilate the blood vessels, which just increases blood flow. At high doses, it starts to have some beta 1 activity. At the highest doses, we have dopamine activity, beta 1 activity, and then alpha 1 activity. So depending on the clinical situation, we'll see different doses in the crash cart for different conditions. Again, suppressor. So all of the neurotransmitters, epinephrine, norepinephrine, and dopamine, we can give them artificially, and they're all considered pressors. All right, those are all non-selective. Remember, they're going to hit multiple receptors, and we don't really get to choose. So now we can talk about more selective agents. Maybe we really want to focus on certain receptors, like how about alpha 1? What's that on alpha 1? So what is the cause? This is a great one. What do we say? This came in with Sudafed PE, phenylephrine. Here's the active ingredient in Sudafed PE. So congestion is caused by vasodilation. Seems a little counterintuitive, just like headaches are caused by vasodilation, right? We think it's always the opposite, but it's dilation. So if we can take a drug that vasoconstricts, we can reduce the congestion. So phenylephrine often is given either oral or intranasally. It's better in a spray, and it's going to act right on the mucosa, vasoconstrict, and we can get rid temporarily of our nasal congestion. Hey, what a great use for an alpha 1 selective drug. Vasoconstriction, not systemic. We're doing it to localize. So these are the products on the market: phenylephrine, oxybenzone, that's Afrin. There's some other ones in the market. These are the most common ones. Afrin is the one probably everybody's heard of. Problem is that people start using them for long periods of time for things like allergies when they're all congested. Has the phenomenon of rebound congestion. So the symptoms are well controlled. People stop using these particular drugs. They get rebound dilation, and they're congested again. All of these drugs, particularly oxymetazoline and phenylephrine, are only recommended to be used 2 or 3 days. And they stop taking it. I've had people on them for years, and they can't stop taking it because as soon as they stop, they're all congested again. It's this vicious cycle. So we want to get people on other drugs if they have seasonal allergies or whatever it is, some nasal steroids to calm that down. This is okay for a couple of days if you've got a cold. You know, you're all stuffed up and you can't breathe. Not longer than that. Here's another selective alpha 1 agonist. So when might we want to keep blood pressure up? Well, if somebody has symptomatic orthostatic hypotension. Now, if they're not symptomatic, we don't care. If somebody's blood pressure drops when they change positions and they don't feel it, well, then we don't care, we don't treat it. But there are people who are quite symptomatic. So the drug that's an alpha 1 agonist is midodrine. And it causes peripheral vasoconstriction, moving all the blood up into the central core and into your brain. Great drug. People with Parkinson's sometimes have some orthostatic hypotension just associated with their disease. And so that's sometimes we use it with that. We certainly don't want to give it for treatment of taking a blood pressure medicine that causes a drop in blood pressure. You don't want to take another medicine for the side effect of the medicine. We use this for people who have some sort of autonomic dysregulation and we need to bring their blood pressure up. But why shouldn't we give it before bedtime? Hypertension, supine hypertension. Yeah, you take it too late and then go lay down. You have peripheral vasoconstriction with no resistance from gravity. I mean, gravity is kind of what is preventing this from, having a lot of bang. You lay flat, you have no gravity resistance. You have massive vasoconstriction and end up with really high blood pressures, 200 systolic and above. So nursing education, don't give it within 4 hours of bedtime, or don't of lying down. They might say, well, I'm not going to sleep, I'm just going to lie down. Don't. It's a hard balance. Midodrine. All right, so that's alpha 1. We had phenylephrine, oxymetazoline, and then midodrine. Alpha 2, clonidine, the big alpha 2 drug. So alpha 2, we said the mechanism of action is we were inhibiting the release of neurotransmitters, which makes it so we don't have vasoconstriction. It's kind of like a double negative. Basically what we have is vasodilation. So if we vasodilate, our blood pressure goes down. Lots of other uses for it. Just keep in mind where it falls as far as sympathetic nervous system. It's an alpha 2 selective drug. I put a lot of links to various videos about things, just ones that I found interesting or helpful. So as a class, the alpha adrenergic drugs, alpha 1 and alpha 2, we have to be careful if we vasoconstrict too much. If somebody already has coronary artery disease and we vasoconstrict too much, we're gonna occlude blood flow even more. And the symptom of that is angina, right? If we are tightening our blood vessels that lead our heart and we're not getting blood flow to our heart, we're gonna end up with chest pain, a symptom of oxygen deprivation. Lots of headache, restlessness, just kind of learn your adverse effects. It's funny that there's both stimulation here, restlessness, excitement, insomnia, stimulation here, vasoconstriction, and yet there's reflexive bradycardia. So palpitations, dysrhythmia, loss of appetite. Loss of appetite, that's very similar to a central nervous system stimulant. People who took central nervous system stimulant drugs had loss of appetite. So you can see anytime we're promoting the alpha world, we have a little bit of stimulating side effects. That's my caveat. Remember, the adverse effects are just the effects of receptor stimulation, and they're just the ones that you don't want. So let's look at beta. Beta 1 has a big group of drugs. Here's again another clip if you're interested in looking at it. What's the drug? All right, so we said under alpha 1, what were the, not under alpha 1, under non-selective adrenergic agonists, what were the 3 big drugs? Epinephrine, norepinephrine, dopamine. Okay, now we're talking about selective drugs. All right, now we're going to look at beta 1. The drug we use is dobutamine, and it's very similar to dopamine, but more specific for beta 1. So you can kind of say, okay, non-selective would be dopamine, selective beta 1 would be dobutamine. And we can use this anytime we need to increase the force of the contraction, especially in heart failure. So people who are hospitalized in acute decompensated heart failure, meaning the fluid has, they shifted out of the blood vessels. It's no longer contained there. It's in their periphery. It's in their abdominal cavity. They can't breathe. They're all full of fluid. Well, now we need the heart to really get working and pump that so that they can pee it out. So we're going to stimulate the heart to pump. Of course, we're going to give them drugs that make them pee. But that's kind of the key for dopamine. You really want to get some increased pump. So you may see dopamine in the ICU with acutely decompensated heart failure patients. That's the one drug I'd ask you to learn in the beta 1 selective category. Beta 2. Beta 2 are super common, and mostly for the bronchodilation, right? Anybody who can't breathe gets a bronchodilator, whether you have asthma or you come in with a RSV, little kids who need bronchodilation, may also get a respiratory beta 2 agonist. Agonist meaning we're stimulating the beta 2 action, but whatever disease we have has caused us to bronchoconstrict, we need to bronchodilate. So we have beta 2 agonists. We have the classes that we are going to talk about are the short-acting ones. So that's your rescue meds like albuterol and levobuterol. And there is a pyrbuterol, but it's not really much on the market in the US. You'll mostly see albuterol and levobuterol. And then we have the controller meds. So these ones are in the system quick, out of the system quick. These ones are your controller meds. In the system takes longer, out of the system longer, right? And we learn them because they end in all this urol, albuterol, levobuterol, pyrbuterol, salbuterol. You can recognize them. Here's where we talked about what are we going to do with the beta 3. So there are lots of drugs we'll talk about in the parasympathetic nervous system that are prescribed for overactive bladder. There is this particular one that is an adrenergic agonist that focuses on the beta 3 receptors in the urothelium of the bladder itself and the detrusor muscle. We relax the muscle so that we can get increased capacity, but there are some adverse effects. So mirabegron, we have to monitor. It does have an adverse effect of hypertension. So we have to monitor for acute hypertension after someone starts this drug. Or we have to tell patients to check their blood pressure because there's a potential for people to become hypertensive. Adverse effects of beta drugs. Adverse effects of the drugs are simply the effects of the drugs that are unwanted. So you might be taking a drug for bronchodilation, let's say, or even vasodilation, but you end up with slowed bowels. Okay, so that would be the adverse effect. But you may take a drug that acts on beta 2 to slow your bowels, and that's what you want. If you have a irritable bowel with diarrhea, and you want to take a drug to slow your bowels, well, okay, maybe we want that drug. Now, these are the adverse effects. The adverse effects are just the effects of the drugs that you don't want. If you learn what the drugs do, or if you learn what the receptors do, then you know what the adverse effects are. We talked about Sudafed. Sudafed and ephedrine, vasoconstriction. How they act. Vasoconstriction in the nasal passages, ephedrine, vasoconstriction. We don't use it in clinical practice. We just use pseudoephedrine. Mixed acting. Let's see, there we go. So how do we, anyone who may have had an overdose, I mean, people can take too much of their beta 2 agonist. Yeah. Yeah. Yeah, there are, yes, different receptors, right? So, right. When it acts on dopamine receptors, it vasodilates. But when the drug dopamine that we give is administered, it's non-selective and it acts on other receptors outside of dopamine receptors. Yeah. No, it's an excellent question because it starts to all blend together. oh my God, all these receptors. And this is like the worst of it, right here. Learn this and you will do well. So people can become toxic on taking too much of a drug. We know that. And so if someone is taking a sympathomimetic and they overdose, you just learn that you need the opposite of it. A sympatholytic, something that breaks down the neurotransmitters or interferes with them. So the opposite of a sympathomimetic is a sympatholytic. And we will come to those when we talk about other disease states. Just know for now that you treat a sympathomimetic overdose with some form of sympatholytic, the opposite. Lots of interactions, obviously. An MAOI can interfere because we said monoamine oxidase is an enzyme involved in the breakdown of a neurotransmitter when it's taken back up into the presynaptic terminal. So if we interfere with that, when you take an inhibitor, we've already interfered with the mechanism of the drug. Adrenergic antagonist, well, duh. If you take an agonist, it's going to interfere with an antagonist, right? Or if you take an antagonist, it's going to interfere with an agonist because they are the opposite effect. We find that sometimes people have been given a medication or like mitodrin, that's an agonist, and then they're also given a drug that acts on a similar receptor that's an antagonist, and it's for their prostate. So that's misprescribing. You can't take an agonist and an antagonist that are acting on the same receptors. Duh. All right. We put a patient on a dobutamine drip. So we said dobutamine is similar to dopamine, but more specific, right? We put on a patient on a dobutamine drip, and he complains that he feels tightness in his chest that he hasn't felt before. What do you do first? It's always check the patient's vital signs, right? I have chest pain. Well, okay, so we know that it's on a drip. So do we check that he's extravasated? Do we check the rate of the infusion? Do we say, oh, I think he needs an ECG? Right now, it's always, we're going to check their vital signs. And these are pretty straightforward. Like we always know, assess the patient before anything else. We don't mess with the drip rate. You will be sued for malpractice. Having something extravasate, so when it leaks into the tissues there, how's that going to cause chest pain? It's not. And yes, they might need an EKG, but obviously that's not the first thing. Might be because of their dobutamine, which we said acted on beta-1, increase blood pressure, increase heart rate, increase the work. So it may be too much for their system. All right, here are patients coming to the ED with an asthma attack. We give them a nebulizer treatment with albuterol. Which receptor does albuterol act on? Beta-2, right? Beta-2 receptors. Beta-2 agonist or antagonist? Agonist, because we want to bronchodilate. So they come in, we're giving them a bronchodilator, a beta-2 agonist. What's the immediate priority assessment? Are we asking when was your last meal, monitoring their oxygen, checking their temperature, or are we teaching them about how to manage their asthma? Assess the patient, right? These are pretty straightforward. Because albuterol is a fast-acting rescue medication, we should see results right away. It's being given inhaled, right? So it's going right in through the lung tissue and crossing that capillary membrane into the bloodstream. We should be seeing your therapeutic effects pretty quickly. All the rest is secondary. Time for a break. That is agonist. It's a lot, I know. Learn that now, and the rest of this life will be easy peasy.
Adrenergic agonist. Adrenergic agonist. Hey, who came in late that Colby came? Lots of more people came in.
They're still, their brothers can.
Yeah, no words didn't come in. I got something. Gladys, right? Probably a receipt. Oh, yeah, you're welcome to all that crazy stuff. Let's see who else. Joan's not here. Did Gabby come in? I didn't see her. She did? Oh, she's back there. You're lucky on checking, because usually I don't double check once I mark you absent. Then you get an evil a letter from Sherry when you've had 3 absences and you're like, I was here. Didn't tell me. Let's see. I know I saw Nasseron come in. I know I did. She's right sitting here. And then Natalie came in, right? She's sitting here. Here. Weren't you sitting here before? No, okay. All right. That was Monday. I'm all lost. That's it. Okay, the rest are still absent.
You guys get, and we're making up for.
I'm good. I
Got a
have.
budget.
But
Oh, and I don't want to say the name, let's see. We'll say. Those I see your.